Good evening, everyone, depending on where you are on this beautiful earth. I'm Vincent Chubaka, and I'll be the first presenter. And before I start with our presentation, I would like to express on the behalf of the overall team our gratitude to the Association of Academic Global Surgery for giving us this opportunity, great opportunity to showcase our research work, especially this one that aim at enhancing, improving post-C-section care and outcomes in rural Rwanda. I'll also take this opportunity, of course, to express my appreciation to our dedicated research team. We are free here in this forum, but we have a very big team beyond us, and I have to acknowledge the support, the dedication, the contribution of everyone. Next. I would like to give a quick overview of our presentation. I will first share a background to contextualize the research we do here in Rwanda, as well as the underlying motivations why we do this work. Then Laban will take the second part of the presentation by sharing one of our innovations, and this one is specifically focusing on post-cesarean section discharge instructions to help actually improve the quality of the postpartum period for those women who underwent C-section. Then Bethany will share another innovative project. That one is specifically focusing at developing a mobile health tool for home-based follow-up after C-section. Next. I'll first start with this report that probably many among us here know about. As you know, in 2015, the Lancet Commission on Global Surgery identified several key messages and recommendations to improve global surgery and anesthesia care. Here are 5 of the key messages from the Commission's report. And the report first emphasized that the lack of access to safe, affordable surgical and anesthesia care, which is definitely needed. With 5 billion people, this is really huge need, who don't have access to effective surgery and anesthesia care. Another highlight from this report is that more than 100 million procedures, additional procedures are needed every year to fill the unmet need, surgical and anesthesia needs. Also, 81 million of people are at financial risk just as they are trying to access quality surgical care every year. And finally, one of their recommendations is around the economic benefit of investing in surgery and anesthesia. Not only this can save lives, but it can promote economic growth. Just investing as the fund, $350 billion can help harvest around $12 trillion if this is applied. And this is definitely affordable. You agree with me as well. Then another message, key message from the report is that when we're talking about surgery, we don't only talk about those procedures related to pure surgery. We also are talking about 2 other components of surgical care, which is obstetric and gynecology, but also anesthesia care. And these are, we can't just separate these. They are together, they are needed as fully part of healthcare. And it's only if we are considering them as a package that we can achieve comprehensive healthcare. And of course, there is definitely a huge need of system strengthening around effective surgical care. Next. Another point to highlight as I'm introducing our work is that around 30% of the global burden of the disease is coming from surgical conditions. And you'll definitely agree with me in answering that question that it's not too small a disease burden, and it's worth to look at how to reduce the burden here. Talking about post-operative deaths, which is also still a big burden, they represent around almost 8% of global causes of death. And this was from figures from 2016. Next. Allow me now to zoom in on what is happening, what we are doing in Rwanda. In Rwanda, can you move the slide, please? Yes, thank you. In Rwanda, we have the healthcare system with that pyramidal shape that we tend to have in different health systems, with at the top the central level, where we have tertiary hospitals, teaching hospitals, which are the national hospitals as well. Then at a lower secondary level, we have district hospitals and what we call provincial hospitals. And down there, we have health centers, which represent our primary care setting, together with a strong network of community health workers. Then until 2016, all specialists were based in the central locations, and these are in those big towns, including Kigali, the capital city. And talking about the surgical anesthesia and obstetric provider density, this has increased from 2012 to 2023 currently, from 0.7 to 2.7 for 100,000 population program, HRH program, which US higher education institutions and the government of Rwanda to strengthen capacity, build capacity, the health workforce in Rwanda, including a specialist in surgery and anesthesia and OBGYN as well. Still, 80% of all operations, surgical procedures, are still performed at district hospital level, not at the central level. And 80% of those procedures are C-sections, and most of them are performed by general practitioners here in Rwanda, just to show again the need for a specialist and to keep capacitating the health system in providing quality surgical and anesthesia care. Next. This is the map of Rwanda. In the center, you can see Kigali, the capital city and the biggest city in Rwanda. Then Partners in Health, the organization for which we work for, Laban and myself, is located in 3 districts. We have the district of Burera in the north, and then, there, and in the eastern region of Rwanda, we have 2 other districts, Kayonza and Kirehe, where we are actually implementing the projects that we are presenting today. Next. The main goal while we are spending energy resources on this particular research project is to increase access to high quality cesarean care in rural Rwanda, with a particular emphasis on enhancing the quality of care during the post-operative period. That is the main reason we are doing this work. And we have a culturally diverse team, as you can see on the picture there. Can you go next? Yes. A very multidisciplinary team also made of clinicians, medical doctors, surgeons, OB/GYN specialists, public health scientists, epidemiologists, and those statisticians. A very, very strong and dedicated team. And together we are trying to bring our contribution in improving C-section care, especially in the postpartum period. Next. Talking about C-section, at the global level, there is evidence that increasing C-section rates are linked to lower morbidity and mortality, and this is good news. However, this comes also with some risks when we compare with women who deliver vaginally. And there are also evidence when you look at statistics from different corners of the world that 8 to 48% of surgical site infections rates are caused by C-section, and this is huge, and a very, very large range, of course, showing the difference in quality from a corner of the world to another. Then, looking at what is happening specifically in Rwanda, 15% of women who deliver in Rwanda give birth via C-section. And this rate can be lower for poorer and those women living in rural settings. I mentioned it already. We have a network of community focus around the country that support women during their prenatal, but also postpartum period. But they don't specifically focus on women who underwent C-section. That is a need. Next. Then why do we focus on specifically on the post-operative period, the postpartum period after C-section? We conducted some preliminary studies to inform our different interventions that we'll be presenting. And one of them showed that around 11% of C-section is associated with a surgical site infection in Rwanda. Which is above the minimum range at the global scale. Also, when you look at the maternal and neonatal outcome, long distances will increase, will be linked with poor maternal and neonatal outcomes as shown by another of our studies. Another study elsewhere showed that C-section follow-up is physically and financially burdensome. And in fact, C-section is financially catastrophic for 23%, which increases to 77% when we consider the care that is needed in terms of follow-up after C-section, including when there are complications like a surgical site infection. I will now let my colleague Laban share one of our projects, the one that focuses on developing and testing discharge instructions for follow-up after C-section. Thank you.
Thank you very much, Vincent, and audience. Thank you for the opportunity to present our research work in this platform. From this background that Dr. Vincent presented, coupled with this one here, We have initiated two innovations. I'm presenting the first one, which is developing post-cesarean discharge instructions for mothers who underwent cesarean in postpartum period. So what were the gaps to cover thinking on these instructions? In literature, we have realized that mothers reported to have receiving conflicting information during their postpartum period. And then during our scoping review that the group conducted, there was no standardized discharge instruction for women delivering via C-section, especially in sub-Saharan Africa. Next. Our project was divided into two phases, and phase one was to develop these instructions, but aiming to answer these questions, these four following questions. What is the message? What should we tell mothers, and when to tell them that message, and when do they need to contact health system, and who can tell them the message developed? Those were four questions that we tried to answer, and this was conducted in Rwanda, and with the aim of generalizing it to sub-Saharan countries as it is similar setting and where it is appropriate. Next. Here it's a team of multidisciplinary participants where Professor Bethany and Dr. Katela were co-principal investigators, and we have a team of nurses, community workers, OBGYN specialists, representative of Ministry of Health. It was a comprehensive team that developed these discharge instructions. Next. What was the output of phase one? As I said, phase one, we were developing discharge instructions, and then you have been able to publish a scoping review about these instructions, and then a guideline paper for cesarean section care. And then in the pipeline of publication, we have a viewpoint, which is waiting to be published. The second document that we ended up having after these technical working group sessions, this is a guiding document with the core instructions about normal recovery, danger signs, wound care, about a message about family planning, medication use after C-section, personal hygiene, what about nutrition, breastfeeding, family planning, and mental health. And then we also worked on the schedule when they can visit the clinic after discharge. Next. In our phase two, it was now having the message from the technical working group. So we're thinking on how we can deliver the message to mothers and effectively. In this phase, we had three aims, and one was to develop strategies that can help to communicate these instructions to our mothers. And then the second aim was to assess their understanding of the content of these instructions via a quantitative survey, and then assess their post-cesarean discharge experience. Then we qualitatively assessed feasibility and acceptability of these discharge instructions to mothers, community health workers, and clinical providers. Next. We have designed this guided by our graphic designer, our PhD graphic designer in Rwanda. And we can go to the next slide for the. You can see we have been able to design two tools. One was a flyer and another one was a blue book. And these were tested to see what is feasible, how mothers perceive the instructions in this, and how was the teaching session. Next. So these are contents that were in our tools. We included a summary about normal recovery, how a mother can know he's normally recovering. What if there is abnormalities in recovery? And then what are danger signs that can make a mother to return to the health facility for care when there is one of these danger signs? And then we have included general instructions that a mother should follow after discharge. This includes wound care, about family planning, when to get contraception, about bladder concern, when to bath, what are the physical activities that are allowed and when to do that, and then clothing. Those are instructions that we included in our tools. Next. What was the method of testing these tools? After developing them, now was the time to test them. And for the flyer, they were handed to mothers in a post-cesarean ward, and then a health provider went to explain to all mothers about what is in the flyer instructions, and then the flyer were taken home by mothers. While free book, a health provider explained using that free book in the ward. That was done between post-operative day 1 and 3. Normally, they are discharged at the post-operative day 3. And then women were shown videos on the free book while the provider had a side of note of message that should be provided to the mothers. And then there was no take-home copy as it was a free book. Next. So we quantitatively assess recall of instruction among our mothers, what was the knowledge retention, and their post-discharge experience. We did this using a phone-based call data collection, and it was done on 14 days after discharge. We had 3 groups of 9 mothers, and the first group was mothers who were exposed to the flyer. The second group was mothers who were exposed to free book, and the third group was considered as a control group. They were not exposed to any tool. Next. As a result of our quantitative survey, most of women at a rate of 93% across all arms, as I said it above, recalled receiving post-discharge instructions. However, women who received this information without the support of a communication tool, which are control group, 43% of them felt less confident, and 33% of them also were less knowledgeable about caring for their body, and 36% of them felt less able to identify C-section related issues. Those are results from our quantitative survey. Next. About our qualitative part, we evaluated the feasibility and the acceptability and the usability of our developed discharge instructions. where we asked mothers, we interviewed mothers, community health workers, and providers. This was done at their post-operative day 3 before hospital discharge. And we interviewed 18 mothers. That means 10 for a flyer and 8 for a free book. And then 4 health providers for each tool, and 1 focus group for each tool. That was our population. Next. Themes that emerged from our analysis, our qualitative analysis, we have realized that they have perceived benefits, where SHW say that this refreshed and enhanced their own knowledge about post-cesarean care. And then mothers say that they were consoled during the education session, and they acquired different knowledge apart from what they had, which were confusing them, not using these standardized instructions. Next. Then they have appreciated about the appreciation about the information that we're providing and the teaching methodology, where they say that the information presented was said to be sufficient and was summarized and understandable, and accompanying to it with the visuals aid them to have enhanced understanding of the message that we're providing, that they were appreciating the flyer that we used. And then others appreciated the interaction during the education session, where providers will, like if I can read one quote, where women say that they were moving, talking to us and showing us different symptoms. They would pick one of us and ask questions. For example, could you read here for us? How do you find this person? Then we answered. This shows saying about how interactive the teaching session was. Next. So here they have healthcare providers have emphasized on a free book, where they say that using a free book, it's very easy to teach a small group of mothers, and then having these visuals and the large text well clearly showing the message. And then they said it was a large design that is visible with the group that they were teaching, and then it was made in a durable and for long-term use. So for the flyer, mothers were highly appreciating flyer, as it can be taken home, and then the message can be spread to husband and the community. And then they said there was a space where they can put a phone number of a health provider so that they can call in case of danger signs. Next. So after presenting the findings of this project, the hospital have highly appreciated the tools, and then they started using it in their routine teaching as a guiding document. And then we are in a phase of validation for Rwanda Ministry of Health, so that it can be scaled up to other hospitals countrywide. And this was used in our tool that we are developing to assess, screen women for SSI and other complications related to C-section. So this will be used, it was tested in our grant that is called RR21 and was positively perceived by community workers, and looking forward to validate the tool for our RR33 grant. As we conclude, post-cesarean discharge instructions were reported to be very beneficial to mothers and CHWs and community and the health providers. And then FRIA and FreeBook were found to be feasible and acceptable to be used to communicate instructions. Thank you very much. Over to Bethany for next innovation.
Great. I'm just navigating my mic and video while I'm screen sharing. So just give me 1 minute. Okay, so I'm going to talk about a second innovation in our work that builds off very much from the last point that Laban was making, which is developing mobile health tools that can be used by community health workers to support home-based follow-up of women after cesarean delivery. And the gaps that we're trying to address here are that community health workers already are visiting women and babies during the postnatal period, and they're providing postnatal care to the babies, and they're providing postpartum care to the women who deliver vaginally. So this was a bit the comment that I made in the chat just now about these protocols already exist and are already integrated into community health worker follow-up as part of standard Ministry of Health procedures. However, women who deliver via cesarean delivery are required to travel back to their health center for specific post-operative care. So even though they're already community health workers in their homes, for C-section specific follow-up, they're expected to travel to the health center for that care. So we saw this as an opportunity for us to address some of the physical and financial burden that women reported during this postpartum period, and wanted to explore whether or not mobile health tools could support women during this period and support community health workers to be able to deliver care to these women during this period. So we had several attempts at this. Our first attempt was started in 2015, where we had community health workers administer simple clinical screening protocols to identify surgical site infections. And then after that, we tried a more traditional telemedicine where community health workers would go to the women's homes and take a photo of the wound and text that photo to a general practitioner who would make a virtual diagnosis about the infection based on the wound image. And through these studies, what we've shown is that these are feasible. So women are accepting of the community health worker model. They're willing to let community health workers come in to their homes to support these types of postpartum care, felt comfortable with wound images, with telemedicine. We've also demonstrated that they are acceptable of this, and this acceptability study was actually done during COVID, during the early months of COVID. And so they were appreciative of the opportunity to stay at home and receive care at home versus having to travel to the health center during that time. However, one big deficiency of these studies is the accuracy of the surgical site infection diagnosis themselves. So it was feasible to do it, but it wasn't safe enough to do it to make this routine practice. So for the simple screening questions, it was highly accurate in clinical settings, but when community health workers asked these questions in the home-based setting, the accuracy diminished. And for the traditional telemedicine, what we found is it actually yielded decent accuracy, but there was low concordance between reviewers. So I might look at an image and Vincent might look at an image and have different diagnoses based on those image reviews. And we think consistency of care is very important in addition to just accuracy itself. And so we're now in the middle of attempt 3, where there are 2 points here. One is that we need to improve our accuracy of the surgical site infection diagnosis. We need to make sure that this is safe if we go to women's homes, and that we needed to make this more comprehensive. So the comment made to us a few years ago was, that's great that you're able to diagnose surgical site infections, but if we really want to be following women who deliver via C-section at home, we need to do a more comprehensive assessment of all the other conditions that they're at higher risk for based on cesarean delivery and operations. So to the first point, one of the things that we've been exploring is developing surgical site infection diagnosis tools that use machine learning, using an image set and diagnosis set that we have been capturing as part of our ongoing studies. So there's a few things I want to highlight here. So the first is that as part of this work, we've developed a wound screener app that can standardize the process of collecting wound images. So here is one of our study team members who's taking a photo of the wound, and it's very much like the check readers on in bank apps or credit card readers. If you're ordering something online, that can automatically identify the perimeter of what you're trying to scan, and then more standardize the capture of the thing that you're trying to scan. And so now we have a set of images that are captured in a standardized way that can be fed more appropriately into these algorithms. We have two different algorithms that we've explored. The first is using the cameras on our phones, which yields decent sensitivity, decent specificity, particularly for the small image set that we have. And then the one that we're really excited about is a thermal camera add-on, where you take the camera and you just add on a modular device that costs about $200, and it captures a thermal image of the wound. And with this, we get comparable sensitivity, but a much higher specificity than we did just using the camera on the phone itself. For the more comprehensive app, we've been taking the recommendations and the tools that we developed as part of the study that Laban described, and we've been programming this into the phone. So effectively, you'll have a question like, do you have thick discharge from your surgical wound? And depending on how the community health worker will be prompted for these different questions, and depending on how the mother responds, at the end of the engagement with the community health worker, there will be a prompt that says, you've reported these symptoms, these are emergency conditions, you need to get to the health center right away. Or it might say, you've reported these symptoms, these are problematic, please try to go in the next 2 days. Or it might say, you haven't reported any conditions, and so you can continue to recover safely at home, and these are the danger signs to watch out for. So we've just passed in the last few months our usability testing. So as part of this usability testing, we tried the app with 30 community health workers. Each community health worker was walked through a series of case scenarios or vignettes. So each community health worker did 3. And out of the 90 completed vignettes, in 90% of those scenarios, the community health worker was able to go through all 10 major steps of the assessment using the mobile app. In addition, we administered surveys to these community health workers, and all reported agree or strongly agree to our usability questions, and all but one reported agree or strongly agree to our acceptability related questions. So as a next step, we've just received our notice of award, our just-in-time request, our pre-notice of award, that we will get 3 more years of funding to be able to validate this tool in a prospective cohort. And then assuming that validation tests pass, the intention is to do a cluster randomized trial where we assess the impact of using this tool on the time to diagnosis of any C-section related complications. So in conclusion, both of this work and then just the other work Laban presented in the introduction led by Vincent, there are clear paths forward for how we can improve care and outcomes of women delivering by cesarean in rural Rwanda. We have focused on cesarean. I know general surgery is a cluster of surgical care needs. Because the main surgical surgical care provided in rural district hospitals is cesarean, we think this is the right starting point for thinking about district hospital care. But we believe that a lot of what we're learning about how to follow patients post-operatively will generalize to other surgeries once capacity for the surgeries increases at district hospitals. The other point I want to conclude with is innovation comes in many forms. So don't ignore practical and pragmatic solutions for bright and shiny objects. People tend to love our mHealth app and not give a lot of attention to the work around postpartum communication and those tools. And so I just want to say that not everything has to be an app. Not everything has to be machine learning. Some of our most pressing needs can be addressed by things like a surgical checklist, which is pretty low tech, but innovative and transformative in the care that we provide. So just make sure that as we're thinking about interventions that we're not ignoring those. And then the last bullet point is actually, I apologize, I pulled this from a presentation I was giving to a group of statisticians. And so it says there's a range of statistical methods and roles for statisticians in this work. think what Vincent highlighted from his slide is there's roles for a wide range of expertise in this work. And so interestingly enough, neither Vincent, Laban, nor myself are surgeons, but we all believe that we have an important role in surgical systems. And so as AAGS thinks about the role of individuals and membership, to really think about how important it is to engage qualitative researchers, how important it is to engage quality improvement experts, that really surgery is a health systems issue. It's not just about what happens in the operating room. So with that, lots of people to thank and acknowledge. There's lots of friendly faces and then folks who've also engaged in this work on the call. So I really want to appreciate you all for listening to us, and we look forward to your questions.
Thank you, everyone. That was a phenomenal presentation. Thank you for the speakers. It was very enlightening and insightful. Now we will be starting the question and answer session. First of all, I would like to invite Senate to ask his or her question for Dr. Vincent, if you're available.
Thank you so much. It's just a simple question. When it was presented, I'm sorry, I was just coming upstairs. The team he was mentioning, I did not hear if nurses or midwives were part of the research team. That was my question. If there were nurses and midwives part of, I myself is a nurse as well. I am from Ethiopia, Addis Ababa, and I am from Lifebox. Thank you.
Yeah, the quick answer is, and thank you for the question. Yes, we can't do a study on C-section maternity without involving nurses and specifically midwives. They are involved, especially in the development of those instructions that Laban has been presenting about. Laban himself is a nurse, and they've been doing great work actually, because they're the ones who spend most of their time with those women in even testing the communication strategy to use either between the flyer and the flip book. We needed again to do it with the midwives, considering also their recommendations and what is the best way from their view to do it right.
Thank you so much. I'll come back. I have more questions and reflections, but I'll come back. Thank you.
Thank you. We have another question from Dr. Lucas Ponte, our IT Vice Chair. Dr. Lucas. Okay, I think he's not available. I will hand over the question to Dr. Mecca Moller, who is asking question.
Hi, good morning. Wonderful presentations, by the way. I really enjoy both of them. I put my question in the chat, and I was just curious. I think this is a fascinating tool, especially to reach communities when maybe the physician is not readily available, but you can use healthcare extenders to help diagnose those problems. My question pertains to the AI part of the algorithm. So we know that AI have difficulty with race when it comes to skin color. So how do you adjust for that when the population has darker skin to ensure that it is accurate based on the algorithms that was used to be created? Because usually this is created by teams of people that mostly have white folks, and there is not much diversity when it comes to skin color.
I'll field that one. This is from my section of the presentation, and I don't know if you can see the slides, but I pulled it back to our wound screener app. So proudly, our machine learning algorithm is developed entirely using images from Rwanda. So all of the people contributing data to our image database that are feeding into our algorithm are the women who we would think would be the beneficiaries of this algorithm if it were deployed. So a couple of comments on your specific question. One, that is absolutely true of the majority of algorithms, but something that we've been working against. But within our work, one of the things that we've been doing is in our wound screener app. So we use this optical target that has these color blocks on them. And this allows us to do primarily adjustment on how skin color and the wound image presents under different lighting. So different types of lighting might make a different reflective pattern on the skin and make the skin appear slightly different colors. So that's one benefit. We do plan to use this to look at some exploration of how to adjust for different skin tones if possible. We're in the process of resubmitting a grant to apply this algorithm in Ghana and Mexico to see if it generalizes. We're quite optimistic that thermal image algorithms could generalize, whereas visible image algorithms may be very skin specific. But if we implement the study and do find that's the case, then we'd be able to build a more robust algorithm, including images from Rwanda, Ghana, and Mexico in the algorithm development. So I hope that answers your question. Totally agree with your comment, but ours is very specific for Rwanda.
I think you're doing a fantastic job. I think it's wonderful, and congratulations. And thank you for answering my question.
Thank you. I have a question from Dr. Lucas Ponte, who is Vice Chair of the IT Committee, regarding pre-hospital care and how we can leverage pre-hospital providers to improve access to emergency care. Drawing on your experience in rural Rwanda, how can community health workers serve to improve the accessibility of emergency obstetric care?
I can try that one, to answer that one. I would say already looking at this is a very, very small project when we look at what can be done in improving accessibility to quality surgical care. But if this can work, if community focus are able to diagnose in a timely manner surgical site infection and other emergencies for those women who underwent C-section, then there is hope that they can, of course, with support with all the technology we are using here, there is hope that they can do more. And of course, we have to consider that those in many countries, community focus are still volunteers. Even if they can do it, even if we can show that this is effective, we have to consider also their bandwidth, knowing that sometimes they're not paid for this job as well. But definitely, community focus, they have a big role in making care more accessible. And this is in general, not only surgical care.
Thank you. The chair of our research committee, Dr. Josh, has had his own question. So handing over to Josh.
Hi, thanks so much again to all the speakers. You know, in the North American settings where I've worked, there have been post-operative discharge instructions processes, but I can say none of them have been quite as thoughtful in terms of language literacy, you know, and ensuring comprehension as yours is. So real congratulations on that front. So from your work, would you say that these sorts of discharge instructions should be really standardized across contexts? Or is there a lot of kind of contextual variability in what you'd recommend to women or surgical patients more broadly? So I guess the subtext is, how easy would it be to roll out your discharge instructions work to other contexts?
Thank you very much. I think I will take this question. And I can start for one who asked about what language is the flyer given in. And our flyers are in Kinyarwanda language. That is the mother language of Rwandans. And about the rate of literacy, data from UNESCO say that we are now on more than 90% of Rwandans, especially female, are able to read. And then coming to your question, we have tried to summarize information that can be captured by mother by focusing on what can show that there is a normal recovery. Just in five words, how can I know that my wound is recovering normally? So then we also summarize, and this went together with the visuals so that you can know, if you cannot read, you can know that if I am having discharge, and it is now, it is, I have a huge discharge, I have to consult the doctor or health provider because I'm having an issue of my own. So developing our tools, we try to simplify it and summarize the message so that it can be captured by mothers simply, either they are knowledgeable. And we think that this can be scaled up to other similar settings in sub-Saharan Africa. It was tested in one hospital and rural hospital, and it was tested to mothers who are in remote areas. So thinking that if it is scaled up to other similar settings, it can work, considering how it was summarized and how we designed our messages and visuals. I don't know if I responded to the question.
Okay. Okay, Josh, you continue.
So I know that there's probably more questions than we have time to get to. But I just wanted to say thank you once again to our speakers. You know, I've certainly learned a lot from what you've taught us about today. So I really appreciate your work and your thoughtfulness in putting this together. I know that there's going to be a couple of words, I think, from Kathy at the end, just on upcoming events for AGS. But if we can just give our speakers a virtual round of applause, really appreciate you. Thank you so much.
Thank you so much to all of you for a wonderful and very inspiring seminar series, and to all our attendees for joining us today. I am Katayin Madani. I'm the Vice President of Internal Affairs for Association of Academic Global Surgery, and I wanted to have you highlight on your calendar December 19th for our next session of the seminar series, which will be embedded as part of AAGS 2023 Virtual Assembly. I also wanted to invite you all to follow us, connect with us across different platforms, and join AAGS. I think today we had an amazing call for our colleagues to join, especially across disciplines. Thank you so much, Dr. Gotia, for that reminder, and Dr. Krishnaswamy for the response in the chat. And if you missed it, once more, AAGS is open to everyone who is involved in academic global surgery. No matter the field, you have the right to be part of this organization, and you are welcome, and you will have the equal opportunity of a voice and opinion, and we need you there so that we can push the needle forward on academic global surgery together. Thank you for being here today, and thank you to our research committee once more, and the leadership of it, Dr. Kamstra and Dr. Isan, and our wonderful information and technology committee, Dr. Ziap and Dr. Ponce, and to our extraordinary speakers who joined us today once more. And we look forward to seeing you all on December 19th, hopefully. Thank you.
Thank you, everyone.